Welcome to This Explainer. Today, we're stepping right into the middle of a high-stakes medical mystery. We're looking at a condition where the margin for error is, well, razor thin. And getting the diagnosis wrong doesn't just mean a delay in treatment. It can literally result in profound, life-altering consequences for the patient.
So, I want you to picture this. A patient is sitting in a clinic, and they've just been given devastating news. The scans show a mass, all the symptoms are pointing in a terrifying direction, they're prepped and facing a massive, highly invasive, and entirely unnecessary surgery for a cancer they don't even have. Just think about the physical and psychological toll of that. It happens because certain diseases are master mimics, hiding right in plain sight.
Okay, let's dive into the true culprit behind this disguise, IgG4 PBD, or Pancreatobiliary IgG4-related disease. It's a multi-system autoimmune condition. So instead of rogue cancer cells multiplying, the body's own immune system goes into overdrive and creates a dense lymphoplasmacytic infiltrate. Basically, that's a massive, swelling crowd of immune cells. And this swelling severely mimics some of our most feared diagnoses, specifically pancreatic adenocarcinoma and primary sclerosing cholangitis. Differentiating this benign but destructive imposter from a lethal cancer is an absolutely crucial high-stakes puzzle.
Section 1. The scene of the crime.
Let's look at the initial clinical presentation. Notice how the symptoms split depending on where the disease actually strikes. Jaundice and cholestasis lead the pack at 40 to 60%. That happens when the biliary system is involved and the ducts are getting squeezed. But then look at abdominal pain. That's present in 30 to 50% of cases, and weight loss at 20 to 40%. Those are classic red flags pointing toward pancreatic involvement. And hovering over all of this, fatigue and malaise, hitting up to half of all patients. It's a real mixed bag of clues, strongly reflecting a combined attack on both the pancreas and the bile ducts.
But the plot thickens here, because this imposter doesn't just stay in the abdomen. It is deeply systemic. As we run down this checklist, you see it can hit the salivary glands in your neck, like the submandibular or parotid glands, the retroperitoneum. The kidney is causing nephritis, the orbital and lacrimal glands around your eyes, the thyroid, and even the lungs and pleura. Recognizing this widespread pattern is absolutely essential, because cancer rarely behaves like this right out of the gate.
Section 2. Imaging the mystery.
Radiologists have given us some incredibly vivid, memorable descriptors to look for on CT and MRI scans. The first is the sausage-shaped pancreas. The organ loses its normal bumpy lobulations and just becomes this smooth, diffusely enlarged shape. The second hallmark is a hypo-intense, capsule-like rim, literally a dark band encircling the edges of the pancreas. When you see these signs, it strongly suggests you're looking at autoimmune pancreatitis. For sure, not a malignant tumor.
So the absolutely crucial point is knowing exactly how to tell them apart. Here we're directly contrasting the imposter against the deadly disease it mimics. Notice how IgG4 PBD gives us that diffuse enlargement, the capsule-like rim, and what's called persistent delayed enhancement, which basically means it holds on to the IV contrast dye longer. Adenocarcinoma, on the other hand, typically presents as a focal, distinct mass with irregular, jagged margins. Spotting these specific imaging differences is quite literally what saves a patient from the operating table.
And this face-off continues in the bile ducts using intraductal ultrasound. Here we're comparing the biliary version of our imposter, IgG4-SC, to primary sclerosing cholangitis, or PSC. Notice the geometry here. The imposter creates circular, symmetrical wall thickening with wonderfully smooth inner and outer margins. PSC? It's messy. It shows asymmetrical thickening, irregular inner margins, and little diverticulum-like outpouchings. So smooth versus irregular duct walls, that's a massive giveaway.
Section 3. Gathering forensic evidence.
Visuals are great, but in a case with stakes this high, we really can't rely on shadows and shapes alone. It's time for biopsies and blood work. You have to be strategic about where you take your tissue samples based on where the disease is presenting most actively. If the pancreas is involved, an endoscopic ultrasound-guided core biopsy is preferred. If it's a pure biliary presentation, you go for a liver core biopsy. And brilliantly, if the patient has those systemic symptoms we talked about earlier, like swollen salivary or orbital glands, you can biopsy those instead. They act as a much safer, more accessible window into the exact same systemic disease.
Once the pathologist gets that tissue under the microscope, they're looking for definitive forensic fingerprints. They want to see that dense lymphoplasmacytic infiltrate, heavily concentrated with IgG4 positive plasma cells. But the real smoking gun is something called storiform fibrosis. This is a very unique swirling, cartwheel-like pattern of scarring, alongside obliterative venulitis, where the veins are literally inflamed shut.
Now, you might be wondering, why not just do a simple blood test? Well, serum IgG4 levels are elevated in 60 to 70% of patients. That sounds helpful, right? But here's the catch. A completely normal IgG4 level does absolutely not rule out the disease. Furthermore, IgG4 can actually be elevated in other conditions, including the very cancers we're trying to rule out. So serology alone cannot crack the case. It's really just one piece of the puzzle.
Section 4. The Treatment Revolution. By combining the symptoms, the imaging, and the forensics, the imposter is finally unmasked. Let's look at how this builds a cohesive, practical medical workup. It starts with Step 1, a detailed patient history, looking for those sneaky multi-organ symptoms. Then Step 2, labs for serology and enzymes. Next up, Step 3, multi-stage imaging to find that sausage-shaped pancreas or smooth duct strictures. Then Step 4, the targeted biopsy to confirm the storiform fibrosis. Once all those diagnostic pieces lock together perfectly, we arrive at Step 5, treatment.
The traditional first-line defense is a bit blunt, but incredibly effective. Steroids, specifically high-dose prednisone, which induces a rapid dramatic improvement, literally shrinking the swollen pancreas and opening up the bile ducts. The steroids are then carefully tapered over 6 to 12 months. However, the disease often tries to make a comeback. For those long-term relapses, doctors have historically had to bring in steroid-sparing agents like rituximab.
But medicine is always advancing, and I want to share a really triumphant climax from the recent 2025 Mitigate trial. We're looking at an incredible 0 bile duct flares in the patient group treated with a new medication called indabilizumab, compared to 12 flares in the placebo group. In medical data, seeing a flat 0 in a recurrence column is just astonishing. Let's break down this MIT GTI trial subgroup data, showcasing this highly targeted therapy, indabilizumab. Just look at the stark contrast. For bile duct involvement, 0 out of 13 patients on the drug had a flare versus 12 out of 15 on the placebo. For liver involvement, 0 out of 2 on the drug versus 3 out of 3 on the placebo. This targeted approach is creating an absolute revolution in completely shutting down the disease's ability to flare up.
The clinical conclusion from this trial is incredibly uplifting. We're seeing higher rates of complete, treatment-free remission and a significant reduction in steroid dose. This is a highly satisfying resolution to our medical mystery. It proves that not only can the imposter be unmasked, but with the latest biologic tools, it can be permanently defeated, freeing patients from the toxic side effects of long-term steroid use.
Which leaves us with this final thought. Think back to that patient at the very beginning, terrified of a cancer diagnosis and prepping for massive surgery. As our integrated diagnostic approaches become sharper, and targeted biologics like indabilizumab continue to evolve and hit those incredible 0 flare milestones, could the days of mistaking this highly treatable condition for devastating cancer finally be a thing of the past? It's a thrilling prospect, and a testament to exactly why solving these medical mysteries matters so much. Thanks for joining me on this explainer. Keep asking questions, and I'll see you next time.